When we talk about staff management, it can contain lots of things, okay? Or you can think of it in different ways. Even delegation can also be under staff management, but we want to look at some small aspects of it. Okay. So under this one, let us look at what we want to talk about under this bulleted point here. So we are saying that never ignore inappropriate behavior by a staff. So when you are working and you see that a staff is doing something or performing an action that is not acceptable, do not ignore. Don't think it is not your concern, so you're going to ignore. That is what this point is saying. Okay. So what you have to do is to ask yourself if what they are doing is illegal. That's the first question you have to ask yourself. If it is illegal, tell supervisor. Okay, you tell your charge nurse or whoever that is supervising you. But if it is no, okay, if it is not illegal, then ask yourself if anyone is in any immediate danger. So after you've asked yourself whether it's illegal or it's not illegal, okay, if it is not illegal, the next question you have to ask yourself is someone in immediate danger? So if yes, you have to confront the person immediately. Let's say you know that, let us use the example. Let us use an example that is related to what we've done so far. You know that someone with a left hand precaution, let's say someone who has done mastectomy as a result of breast cancer, a left one, you have to keep arm precautions, like left hand precautions for the person. So you find out that a nurse is going to, a nurse taking care of this patient is going to draw blood from the patient's left arm. That is one common example you can give. Okay. So if the action will result in immediate danger, then what we are saying here at the last bulleted point here, it says if yes, then confront the colleague. Okay. Confront the nurse or your colleague immediately, because you don't want to delay to put someone at risk if behavior is, sorry, to put someone at risk. So there's a full stop here. Okay, so you don't want to delay if what the person is doing is going to put another person at risk. So you have to confront. And we are saying if there's a full stop here, okay, like I said. So we are saying if the behavior is legal and it is not harmful, but just simply inappropriate, then speak with them later on. Okay. So if let's say it's something that um let's say we use alcohol rub, okay. We use alcohol rub, or instead of you to use a cotton to clean a cotton or maybe a gauze to clean let's say a blood or part of a body which is oozing, you take tissue or you pull something that is uh, almost unacceptable, okay, to clean. Or let's say if you use about two gloves, you wear two gloves altogether to empty urine. You know, this one, it will not it's not going to cause any immediate harm to anyone. Okay, it is just inappropriate, and it can wait for you to later address it after he or she is done with whatever he is doing. Then you can later address it. Okay, but there are some things that you will have to intervene immediately. Let's say if you find out that patient is being served with a wrong type of drug, or even if it's the right drug at that time, would that drug be right? Let's say you are in the facility, or let's say you're on a shift with a colleague nurse, and the colleague nurse is going to, let's say, serve or give metoprolol. Okay, you know that metoprolol is not given when heart rate is below 60. And you yourself, you know that patient, or on the cardiac monitor, you see that patient heart rate is 60, is about 50. And this nurse is the rightful nurse, caring for the patient. So you being a bystander, as soon as you see your colleague nurse going to administer metoprolol or any beta blocker to a patient with heart rate of 50 or 55, you don't have to wait to intervene. You have to step in immediately. So you can give lots of examples, okay? But if there are minor things that will not lead to any immediate danger to anyone, then you can let the person finish. Then after you talk to the person that this and this way is how it's done. Please, you understand what we are talking about? That is the kind of idea we are trying to portray. Is it clear? Anyone with any question here? But I hope you can hear me, right? Can you all hear me?
Yes, sir.
Okay,
Yes,
okay.
sir.
All right. Then let me ask you a question if no one has a question. So this is my first question. Who can read for us?
So please, what topic are we
It is
treating?
6:30 p.m. It is
Hello, sir.
6:30 p.m.
The one asking you were late, right? Please, you're laughing. Carry on, okay?
I'm confused.
Next time
It's
you come to the message.
6:30
So this is what you're
p.m.
talking about. Staff management, okay?
Uh,
Yes, carry on. Uh-huh.
It is 6:30 p.m. and you receive a call from a newly hired nurse who is scheduled to work at 7 p.m. She tells you, the charge nurse, that she is sick and will not be able to come in. What should you do? 1. Inform her that 30 minutes is insufficient time to find a replacement, so she will have to come in. Instruct her that she must speak to you the next time she comes in and attempt to find someone to replace her for this shift. 3. Document in her file that she failed to give adequate notice for calling in sick. 4. Tell the oncoming child nurse that the new nurse called in, so the staffing will be short for the evening.
Okay, a very practical question. Who can try and answer? Who knows the answer? Anyone at all can try.
Sir, please,
Hey,
I think it's
yes.
I'll,
4.
yeah, I'll go
Sir,
in
please,
for
I think
4.
it's 4. 4.
Okay, why do you think it's for?
Sir, please, I'm trying.
Yeah, oh,
Please,
yes, we are all trying. Don't worry. Try. Okay.
I feel it is 4 because um she she has she has been she has called in sick. She has called in sick at least ahead of time. So the the um the the oncoming nurse, the
Mm-hmm.
oncoming child nurse must be a tell the oncoming child nurse. Yes, so the oncoming child nurse must be able to try and get someone to replace her.
Okay.
That is it. Yes.
Okay. Okay. Are we all choosing four? If you have a different answer, be bold. And if you agree to four too, let me see.
I chose one
Because
because it is too late. 30 minutes is too late to find somebody to come. So
okay.
I'm sure she wasn't sick within that 30 minutes. She was sick before, so she would have to report. And
Okay.
later she learned.
That
Okay.
would be typical of
Are you a
Ghanaians.
charge nurse in Ghana?
Yes, please.
Ghana,
Oh, I
Ghana,
see.
number one would have corresponded with an average Ghanaian nurse.
Uh-huh. So that's why
Exactly.
I asked my
Because there
sister
can
whether
be
she's a charge
emergencies,
nurse.
so 30 minutes.
Well, I think number four might be the answer because, I
Okay.
mean, calling in the oncoming nurse to let her know that it's 30 minutes and probably she may not have enough time to call in another nurse that, okay, or find a replacement. So the best thing is to let the other oncoming nurse, charge nurse to know that they will be short-staffed. That's
Okay.
my...
Okay. Do you know what is interested? Sorry. Who wants to try again? I saw someone's hand up and the person put it down again. So do you know what is interesting about this topic and all our contributions? We've left the correct answer somewhere and we are beating around the wrong answers. That is one thing interesting about this question. So the answer is two. And let me tell you why it is two. So that when you get similar questions, you can use the explanation I'm going to give to focus on or to make application so that you can get similar questions correct. Okay. So let us understand the question first. I'm taking you back to the question, then later we'll come back to the option so that you can appreciate what's happening. It is 6:30. Normally shifts. I think it's even here in the question. It says that shift start at 7. So it is 6:30 p.m. and you receive a call from a newly hired nurse who is scheduled to work at 7 p.m. So she tells you are the charge nurse here. Okay. So she tells you that she is sick and will not be able to come in. What should you do? So look at there are two things here. Don't You shouldn't be biased. Address address everything here because that is what has been given to you in the question. So one, we all agree that the patient called in late, right? So yes, we have to address that part that the nurse called in late. You can't let it slide because it is inappropriate and you shouldn't allow it to slide. So you have to pick an answer that addresses that. And at the same time, you can't force someone who is sick to come to work. Over you can't. Over here you can't. If the person is sick, even if the person is not sick and the person tells you he or she is sick, what will you do? And mind you, over here it's not like Ghana, okay? Even anytime, any day, people can stop work and they can. It, things are very free here and liberal. It isn't like some parts of the world where it will be difficult for someone to quit his or a job. Someone can quit today and start another one tomorrow. Okay, which could be even be better. But not even saying that. I'm just stressing on the question and what it comes with so that you will understand it and appreciate it. It's the place I'm coming, okay? So you have to address that inappropriate behavior for calling in late. Then the nurse can't make it for the shift. The patient who would have been cared for by that nurse should not also be left without a nurse. So they should also have a nurse, no matter what. Even if it's 5 minutes, they should have a nurse. So you pick an answer that addresses both of them. Do you understand what I'm trying to say here?
Yes.
So with with the explanation that I've given, among all these four options, which one do you think addresses both of them?
Number two.
I chose two in the comment section and deleted it.
Because you were
Number
not good enough.
I
All
said
right.
the
Esther Philo's hand was up. Esther Philo, please ask your question.
Yes, sir. Thank you, sir. You see the number two,
Mm-hmm.
the last point, which says an attempt to find someone to replace her for the shift.
Mm-hmm. Is it the
Okay.
English?
Yes,
Uh-huh.
it's the Brofo.
Is the
It's
English?
now
Okay.
understood.
Yeah.
So it's the in charge who will find somebody to replace her, not she herself.
Yes, not the nurse who keeps coming. The nurse
Okay.
who is calling off don't have any staffing role or any staffing power to bring someone in. So it falls on the charge nurse to make arrangements.
Okay. Well
Yeah.
Okay.
So that's
understood.
the meaning of the English. Okay.
Yeah.
Yeah,
Thank you.
it sounded a little bit ambiguous.
Yeah.
Yes.
So you can understand the last part if you look at the first part well. Instruct her that. So who is instructing? So it's like all the actions here are being done by the charge nurse. You see
Okay.
this one. Instruct her that she must speak to you. So it is the charge nurse who is in action right now. You see how it began. And fine, so it is still tied to the charge nurse. Do you get it? And do you appreciate it?
Yes.
Yeah.
Yes.
Yes.
So whenever you get questions like that, always focus on the solutions, not like blaming or how you can get someone punished or what can make someone. You see, don't try and pick answers that does not focus on what is happening or that is trying to beat about the bush. Try and pick. So this is just one question. Okay, you can get similar ones in different ways. So whenever you get similar questions, try understand the question and pick answers related to what can help in the resolution of what is happening and not bias, like try and address both ways in appropriate manner. If you have that in mind, you are likely to get or to choose a correct answer. Sister Cecilia, your hand is up.
Oh, please. My problem was the instruct. I was thinking the instruct isn't properly.
So the instruct could be like tell her, okay.
If it
It,
were to be tell her, like,
it is so it is the English. It is same thing, the English. Instruct her. It's like you're asking her to come and see you.
mm,
Okay. So which is
mm,
an instruction you are giving? Are you there? So option two is correct. The rest
okay.
the rest will not address what is happening fully. Any other question before we move on to the next one? So sometimes I bring up these questions, some of these to open our eyes to see how questions can be asked and how you should think when you get similar questions. Okay.
Okay. Please, my hand is up.
Okay.
So I wanted to know what if you said when a person is doing a wrongdoing, is doing
A
something
wrong
that's
thing.
wrong and someone is going to be in danger. What about if the person herself is going to be in danger of the acts he or she is doing? So probably what we have nurses that do taking drugs, I don't
Yes,
know,
control
like
drugs.
petrodine and
Yeah.
those things. So with that, do you ignore it or do you still have to do something about it?
Yes, so thank you. It's a nice question. So, controlled drugs in the Western world is a very, very big issue. Okay. When you are caught in this act, it's like you have an issue with the board of nursing, and even if it depends on the extent of it, you can even have an issue with the state or with the federal government. I mean, it's a very big issue. All right. I don't want to go into politics, but those of you who have been following international politics, even
Mm.
a head of state was even was even taken because of, and I mean, I don't know whether it's true. I just heard it, and it's in the news because of narcotics, right? So
Mm-hmm.
it's a big issue. And what we have to do as nurses is that is why, you see, before I say this, that is why most people over here say that these people, they are gossips. Anything that they see, they can't shut their mouth off. Okay, they will just send you, or they'll just tell whoever needs to hear it. So the idea, or let's say the deal, is that whenever you find or you see your colleague nurse trying to steal a narcotic which belongs to a patient or whichever, don't confront the person. Just tell the charges. And this how it's going to be. Um, Maybe the charge nurse is called Cecilia. So Cecilia, I think I saw maybe Philip putting something that might be maybe a drug or something in his pocket in the medication room. Okay, so you can cite it that way because you actually didn't see the person or your colleague taking a narcotic. Okay, I mean, you've not seen what he took, like, physically, but you suspect, and suspicions can be highly true. You know that it's definitely a narcotic, but because you did not see the label on that drug which has been taken, so you can present it in that way. You think you saw maybe Philip putting a kind of medication in his pocket. Okay, so you thought the charge nurse. It is your duty, and you don't have to sit on the fence on it or turn a blind eye to it. When you see something, say something. That is what it is, especially for narcotics. There are questions around this thing that you ask, and the example I'm giving. Please, the English trap about that part is that confront the nurse or the colleague nurse and ask maybe what did you put in your pocket or something. No matter how garnishing that option will look like, please do not confront anyone you see or you suspect has stolen any narcotic. You can be in danger, immediate danger. So do not confront. As soon as you see, the correct answer to those questions are just report. The correct answer is not turn a blind eye. The correct answer is not confront. The correct answer is not to ask. Sometimes do not say confront. They'll tell you ask the colleague nurse what he put into his pocket. Asking him in that manner is like you're confronting him, but they might put the option in different way. So you don't do any of that. As soon as you see, quietly you tell the charge nurse. Please, have I answered you? And is it clear? Okay. The one who asked the question. Okay, let's carry on. We have a next question here. Which of the following statements regarding communication is not true? This is just A general question. Which of the following statements regarding communication is not true? The question looks simple, but mm-hmm. Hey, are we here? Am I
Hello.
online? Yes.
So I'm going for A.
I'll
You are
go
going for
for
A.
A.
Communication is an
I'll go
essential
for
skill for leaders. Okay. Someone says she's going for what, C.
I'll go
Yes.
for
Okay, poor communication affects care coordination. Okay.
I'll
So
I'll
I'll
go
go
for
for
also
D.
go for D.
So some people
I'll
I'll
go
go
for
for
D.
D.
some people
D for
are
dog.
some people good. Some people are not looking at this. So they're only looking at you. Some people are not looking at this.
So, I'm going for A because
Mhm.
communication is not an essential skill for only leaders.
Wait,
But,
did we say only leaders
but
or for leaders?
surely leaders need to have that communication as
No, no,
essential
no,
skill.
wait. I'm asking a question. When you were saying you said for only leaders, the question say only leaders.
No.
No,
No.
What did the question say?
for leaders.
Leaders. So in
Hmm.
that context, will this one be correct or wrong?
They didn't say you are not a
Mm.
leader.
So, so you see, when you are picking answers or you are reading in your mind, read it exactly as it
Mm.
is, so that you can
Mm.
understand it exactly as it is. As soon as you add the only to it, it means A2 can be true. It can be the answer. Do you know that?
Mm.
If you add only to it, it means A can be the answer.
Mhm.
But there is no only here, which makes it or which gives it a different meaning. So let us pay attention to some of these things. All right. Many people were choosing D. What is your reason for choosing D?
Yeah, can I try?
Yes, please, you can try.
I went in for D because it says the question says regarding communication is not true. So here we are looking for the negative one, negative
Mhm.
answer. So communication is essential for leaders. That one is true. And then effective communication can motivate and engage others. That one is also true. And then poor communication affects care coordination. That one is also true. So
Mhm.
here it looks like communication is easy to measure. That one is not true. And I don't think we can measure communication. Uh, so that's why I went for D.
Okay. Thanks. How you sorted your answer is very nice. Like it's perfect. Okay. Yes. So you see, this one looks like a simple and a straightforward question. But you see that some of us have still managed to get some of them wrong. So when you get questions like this, take your time. So how our sister just picked out her answer. That is one way you can fish out your answer. Okay. You are looking for something that is not true. So you mark out the things which are true, then you know that they can never be the answer. Then you by all means be left with one, which is likely not true about communication. Then that becomes your answer. Okay. Let's look at the rationale why we are saying that. Are we there? Can we move on? Okay. So let us move on to something else. So we are done with staff management. Okay. So that aspect is just an experience to expose you to one other aspect of fundamentals. Okay. And how to answer questions on them. Should you get anything similar? So now to talk about a different thing here. That is our responsibilities when it comes to surgery preparation. Okay. All right. I think for this one, it's not anything new, right? It's not anything new. Almost every nurse, I mean, has gone through these things in nursing school. But let us go through one or two things just to rekindle um, some of what we've learned. All right. And if there is anything new, we shall add up. So, when it comes to surgery preparation, we have the pre-op, the intra-op, right, and the post-op preparations. So as part of the pre-op or pre-operative nursing responsibilities, we've thought about a lot of things. You know that you have to make sure that the client's allergies are noted, okay, and their history that they came with, every bit of them are confirmed, right? Then you also have to make your thorough assessments. You have to confirm whether consent form has been signed, okay, and in the right way too. You are advocating for the patient, remember that, and ensure the patient has been MPO as indicated. So you will normally stay with the patient overnight if it's inpatient. Okay, so you have to make sure that the patient is kept MPO, that's no pills, nothing by mouth. Then client voice before surgery. So before the client is put on the theater table, before the client goes into the room, we should encourage them to voice. Okay. And the next one or the last one we have on the slide is witnessing that the correct surgical site has been marked. So if let's say you are going to do above knee amputation for our right leg and mistakenly we do not check and the left leg instead is being marked, that is a very, very, very big issue, or that would be a very big issue. Okay, so that's what we are trying to talk about. And you make sure that you have your correct, to add up to it, you have to make sure that you have your correct client, the procedure is right for the patient, okay, to perform. And you also have a duty to confirm whether the right surgeon is the one going to perform. Not that I mean that the surgeon is better than any other person. But I mean the surgeon has been booked for that particular case. Okay, so you ensure all of that. Then most of the times MPOs, it depends on the procedure, but most of the times MPO status um for NPO status we normally keep them between 6 to 8 hours, right? Yeah, something like that. And the reason for doing that is that we want to prevent them from aspirating, okay, from aspirating, especially when you have anesthesia drugs kicking in. Okay, yes, so we don't want that. So that is why, I mean, that is why we give them MPO to prevent aspiration, right? All right, the next one. And if you get questions and I mean on these things and you tell you the client X, your priority thing is to tell the surgeon. Don't tell the client that you have cancelled it or maybe something like that. Just tell the surgeon what has happened. So if the surgeon would want the client to reschedule, then it will be from the surgeon himself, right, or herself. All right. Um, what else can we talk about this one? Yeah. So apart from being keeping patients MPO, vital signs are also very important, and some laboratory investigations, right? Allergies. Remember, we have lots of people with different kinds of allergies. Confirming that you have to make sure that, especially vital signs, is very, very important. When you have extremely high heart rate, let's say around 180 and above, it will be difficult for a surgeon to take you to the theater unless maybe something is happening seriously and the benefit of the surgery overcomes what is happening, especially with the blood pressure. But until then, no surgeon will go in and perform any surgery. Okay. Yeah. So it's very important. Then another thing too is that you have to check patient medications to make sure they are not taking anything which could lead to contraindication or which could lead to postponing the surgery. Let me give you an example. When a patient is about to go and you give patient beta blocker, anesthesia agent will cause hypotension. It will bring your blood pressures and vital signs. I mean, it will bring things down. So when you give any antihypertensive, you worsen issues. Do
Please,
you get
Brian,
it?
your voice is down.
Oh, sorry. Can you hear me now? Is it fine now?
Yes.
Okay, thank you. All right. So you have to make sure that some medications are not taken. So an example, let me give you an example, like anticoagulants. Okay. You know that when a patient is going for surgery, you hold anticoagulant, okay? Otherwise the person or the patient can bleed a lot. Then sometimes we also ask if they take some herbal supplements. Do you know those herbal supplements that start with G? Do you know them? Ginseng, garlic, ginkgo baobab also. All right. All those G, and I think ginger. Those
Go
herbal supplements.
below board.
They can cause or they help thin blood, so they can easily let you bleed if you've been taking them for long. So we have to screen you too for it to see if you take them or not. All right. Then sometimes too, oral hypoglycemics too. Sometimes you have to hold. Who can give me an example? Like okay, let me start. Do you know that who knows? Let me put it in the form of question. Who knows the link between metformin and maybe anesthesia agents generally? Who can tell us? Franklin.
Okay. What I know is that the interaction can lead to what we call metformin associated lactic acidosis,
Oh.
Okay, say it
lead
again.
to a buildup of lactic acid. Metformin associated lactic acidosis.
Okay, yes. So generally, it is recommended that, thank you. Okay, so generally, it is recommended that if you're on metformin, so that's just an example. Okay, if you're on metformin, for instance, it should be held for about 2 days, okay, before the surgery, so that I mean, you prevent getting or you avoid getting lactic acidosis. I mean, in short, lactic acidosis, if that is what can stick into your head. Okay. Yeah. So we'll not go into the mechanism right now, but it's just an example.
Come,
Yeah. Okay. And
be pushing chairs.
okay. All right. Let's carry on. I think that is what I mean, that is all I can say right now. Um what else can we say? Yes, so you can, when it comes to the jewelry, I mean personal items like jewelry, dentures, some patients wear contacts and all of that. And if there is a makeup which will affect surgery, you wipe all those things, right? Yes. So let me ask you a question. What about insulin? What can you say about insulin?
Hmm.
Yes,
Babe,
Sir, please, like
babe,
insulin, like someone who is undergoing surgery or what, and
yes.
is taking
So will
babe.
you increase? Will you? My question is, will you increase insulin or you will decrease insulin when you
Next
are going
time,
for surgery?
increase.
when I'm putting the bank in the freezer, in the
You know that
Some
during stressful events, there's a
don't
likelihood that blood
someone
sugar.
someone is not talking to us, but the person is talking behind. We can hear your voice. Yes, carry on. Mm-hmm.
he said it's
I was saying that you know that during stressful events, for example, surgery, blood glucose levels rise, and that would demand um the healthcare provider to increase insulin dosage.
Come again.
I was saying that
Mm-hmm.
there's a likelihood that we will increase insulin dosage because surgery is a form of a stressful event. And during stressful times, blood glucose levels tend to rise up.
No,
Okay.
you instead
I
reduce it
think you
75 to 80%,
But
or you
if
withheld it.
that person
One,
is
one after the other,
person,
please. This is a very nice
what will it
question. Who wants to talk?
I think you would rather have to reduce the insulin because before the surgery, we should bear in mind that the patient is and is going to be MPO, and he's not going to be eating for some time. So if you increase it, the patient risks of going into hypoglycemic shock.
It's
Yeah.
like okay, okay. Franklin, your hand is up. Franklin,
Hello?
yes.
Please, uh,
Hey, Frank.
when you give the insulin, as the sister was saying that during stressful situation, I disagree with that one because the question that came to my mind, what if that particular patient you are giving the insulin has problem with insulin production? So I think the better thing to do is either to reduce it or not to give at all, because you may also give and it will also affect the potassium level of the patient.
Hey, someone is overthinking. Oh. Someone is overthinking.
It is
Someone wants to
supposed to
even go to
reduce.
potassium.
They say
Mr.
to
Abigail.
reduce it by 75 to 80%.
Oh, okay. After Mr. Abigail, then you come in, okay? Mm-hmm.
Okay, so far, this patient is still on MPO, meal per hour, and it's a diabetic patient. We
Mm-hmm.
bear in mind that this patient, we are starving the patient. Okay. Once we are starving the patient, it means we are still controlling the sugars. This patient is not eating
Ah,
sugar.
shall anyone.
The patient is
Mangpa
not
Mm-hmm.
ka
eating
wera
sugar.
ba.
So
Ah,
UAT the dosage of insulin will run the patient into hypoglycemia. Okay. And then it even kill the patient. So
Okay.
it's either you decrease the dosage depending on the fasting blood sugar in the morning before the surgery, or you don't give at all. So it will depend on the fasting blood sugar. That will help
Okay.
you decrease or to avoid it, to avoid
Okay.
giving up. Thank you.
Okay. Okay. I think we've all established the answer, right? So, since they are kept MPO, even for long-acting insulin, sometimes the NCLEX, they might think when they give you an example, let's say when they give you Lispro, Lispro is a short acting, you'll get it. So they can ask you in relation to long acting. Okay. Long acting insulin works throughout the day for almost up to 24 hours or between 18 to 24 hours, depending on the type. Okay. Just note that with regards to long acting insulins too, they are reduced. Okay. I mean the night before. The rapid one, the rapid one, they act immediately after giving. So those ones, they are withheld, especially if the patient has been kept MPU. It doesn't make sense for you to, when the person has been kept MPU or you are keeping the patient MPU, that glucose is likely to drop down already. So you can't give any rapid acting insulin again. Otherwise, hypoglycemia can kill the patient before you realize. Okay. And for long acting too, if they should take between about 20, 30, up to about 50%, up to half of it. Okay. Up to half of what you've been taking. So if you've been taking let's say 60 units, you have to take what? Up to about maybe 30 units or so. Yeah. Please, is it understood? This is a nice thing we brought up. Okay. It's a nice thing we brought up. And yeah, so let me so this is before surgery, right? Now, when I was about asking this question, someone also brought in something. So my next question is, do we increase or decrease insulin when you are sick or during sick days?
So please, you increase insulin.
So what makes this one different?
This time you are sick.
This time you are sick, eh? That's a very simple and
Self
short answer.
demand for insulin is more because of
Okay.
the
Okay, so the answer is simple, eh? When you are sick, sickness itself is like a stress on the body. When you are sick, you have hormones being produced, like the adrenal hormones, catecholamines and whichever. Okay, they are being produced. It's like a stress hormone. Okay, you have stress hormones being produced, and whenever you have these stress hormones being produced, they are steroid. They are like steroid. Okay, should I say steroid? They are
That's it.
yes, they are like that steroid, and they increase your blood glucose level. All right. Whenever you are sick, the sickness is a form of stress. It increases hormones, catecholamines, and all of these things in you. They stimulate. It's like your adrenal cortex is being stimulated to produce all these stress hormones, and they cause increment, or they tend to increase your blood glucose level. So in this case, we will have to what, increase your blood sugar level. That is why it makes sense. That is why when you have diabetic, when people with diabetes, right, when they are sick or when they get emergencies, you see that their blood sugars go very, very, very high. Do you understand that? Are you appreciating it? When, let's say, no infection has set in and they are having their normal condition, even though, yes, they are diabetic, if they are having their normal diabetes and working, sugars are high up to a level and they're able to go and come do their things. But as soon as, let's say, infection sets in, if, let's say, they were recording around 12 to 15, they'll be recording later 20s. Have you realized that when they are sick? So that will make us increase their insulin demand. All right. So all these are just by the way, but they are hotspots, thankless hotspot questions. Let us carry on, okay? I think we've said enough. Then teaching patients breathing exercises. This Abigail, is it an old hand or a new hand?
A new answer.
Okay.
Please, I wanted to know, some of us then, when you are stressed, you tend to put on a lot of weight. Could that be as a result of what we are just talking about?
Yes, it is a similar mechanism. When you are stressed, you
Okay.
have a lot of your adrenal cortex producing. Is it, I think it's the cortex, right? Which produces all these stress hormones. Yes, I mean the steroids,
Yeah. Yeah.
corticosteroids. Yeah, they are produced, and steroids make you bigger.
Okay.
They make you gain
Okay.
weight. Okay, they increase your blood sugar level. They make you gain weight. Yes.
Okay. Thank you very much.
Okay, me
So
when I'm stressed to lose weight too.
yes, but it's not the same for everybody. Okay. Yeah, we
You've
have
seen
we
all
have
sort of
different.
gifts.
Yeah, but
Hmm.
that mostly
Flowers.
mostly that is what happens. Yeah, for those who become bigger or who grow fat. All right. I think we can continue. So the rest we can just think about it, right? If patient has fever before going to surgery, we have to tell the provider. I mean, all of these things we already know them, right? So we will not talk about them, right? Oh, I don't have any question on this one. So I think we've deliberated on this for some time. So if you have any question on this or anything to add on maybe what we should be mindful as part of our responsibilities prior to surgery, you can bring it out. Any other thing to say, to add, to ask? If they have dentures, you have to remove. I think I said that right. Then what else? What else? Then sometimes nail polish is removed. Why is it removed?
Yes, you too.
Good.
And access
It
You
it
too.
affects pulse oximetry, yes. When you want to measure the SpO2 with the device, the probe, it affects it. Any other
Especially the
question?
The black nail polish.
So any polished nail, okay, or any nail polish, you remove them.
I don't know.
Okay,
I don't know yet.
Francis, your hand is up.
Yeah.
Ah, yes, boss.
I already have a boy.
Let's talk,
Hey.
okay? I've muted the person. Let us talk. Uh-huh.
Okay, boss. Thank you very much. I don't know if you've mentioned that, but what of wedding rings? What do we do
Yeah,
with
so
that?
yeah, so I made mention of jewelries.
Okay,
Sometimes
okay.
yes, sometimes it is very important to keep all these things to prevent, sometimes not with the reason that it can get in the way of the surgery, but to prevent it from getting missing. A lot of things happen during surgery, I mean the transfer and everything. So most of the times when they come and there's a family member, you pick them, you document, and you give them to the family member to take it home. If the family cannot take it home, you document and you send it to security, but you let the patient know. And you do that if it's something valuable, maybe you do it with your child nurse or another nurse so that you can be safe. Are we there?
Yes, sir.
Okay.
Hello, sir.
Yes.
Please, what was the conclusion? The surgery and insulin debate. What happened?
Surgery and insulin. So you said
Yeah.
when you are going for surgery, because you are kept MPO, you don't take any short acting insulin. It is contraindicated. Okay.
Oh, okay.
And for long acting insulin, you can cut them by about 20% to about 50%. You cut them, I mean you cut it down. Okay.
Okay.
Yes, but for short acting, it doesn't make sense if patient um has been kept MPU and already the sugar levels are down, then you give a short acting again. You kill the patient before the patient even realize.
Oh, okay. Thank you.
You are welcome. All right, let us continue. So let us look at some positions, okay? Gracie, your hand is up. Gracie, you're not talking to us. Your hand is up. You are
Sir, please.
muted.
Yeah, so sorry about that. I'm
Okay.
just adding a point to the ring, I mean the jewelries. I think I'm already in the state and I've experienced a case where um
Okay.
somebody, I mean, came in and didn't want to take off the ring
Mm-hmm.
because she said she feels when the ring is on, she feels the partner is with her in the theater. So
Okay.
yeah, I saw them taping it. Like they
Okay.
taped it with either like I don't know, let me say a tape.
Mm-hmm.
Like they
Good.
covered it to
Good.
make it, I mean, sterile. Let me put it that way.
Okay.
So in some cases they do that. So I just wanted
Okay.
to add that.
Okay. Thank you. So it could also be that the taping it or by taping it is to make sure that it doesn't get missing. So in both ways, okay, or maybe maybe in both ways.
And sorry, please, me
Yeah.
too, it happened to me.
Mm-hmm.
I had a nose ring when I was going for my surgery, C-section.
Are you in the
They
US?
couldn't, I'm in Canada.
Canada, okay. So US and
Yeah.
Canada, we also get the nose ring some, okay. Uh-huh.
Because they couldn't remove it because it was stuck.
Okay.
They tape it.
Okay.
Yeah, they said it
Okay.
was going to interact with the
With the surgery.
anesthesia. Yeah.
Oh, anesthesia. Okay.
Anesthesia agent.
Oh, okay. Okay, yeah. Good. So if it will affect the surgery, they'll cover it, right?
Yeah. So they tape it.
Oh, okay. So to prevent infection, and I think to prevent lost tooth is also part, maybe, I'm sure. Because
Yeah.
when a patient accuses you of maybe a missing jewelry, you have an issue. Okay. That's why we have to play our part as nurses so that we don't fall into that pit. All right, thank you for your contributions. Okay. Now let's talk about this one, positioning. Positioning, various positionings that we can think about. We can, I mean, we might talk about lots of other things so that are not here, as and when they come. Okay, but let us look at what we have here first. So positioning clients. Most of the time, before and after procedures, the analysts ask a lot of questions about this. It got to a time, everybody, I think somewhere middle or early last year, everybody comes with like positioning, like, oh, it was like a trend. It got to a time, everybody, yeah, I'm saying this here. Okay, no problem. But I mean, it was a hotspot area. Okay, let me cut it short that way. So what we can talk about on this one is that the first one, okay, let us talk about the first one. We are saying high foulness for paracentesis. So when a patient is undergoing paracentesis, I hope you know paracentesis. When we are draining fluid from where?
Yeah,
Abdomen,
Abdul.
right? Okay, good. When you are draining fluid from the chest, it's called what?
Paracentesis.
Thoracentesis. So that is thoracentesis. Paracentesis is of the abdomen. Okay. As in example, like ascites, when you have ascites, and yeah, so that is paracentesis. All right. So high foulness for paracentesis. Okay. And high foulness too, I think for thoracentesis too. Sometimes they'll tell you with your arms over a heart table, okay, in that upright manner. It helps to open up your intercostal spaces if it's even if it's thoracentesis. So that can also be done. Okay. The next one we are saying treadlemmic position and on the left line side, if suspected or if air embolism is suspected, that is what we're saying. Okay, so this one, what it means is that as soon as you suspect air embolism, first thing is that let the person lie flat. Then, treadlemic is like a flat position, right? But it's like opposite of powerless, right? But in a flat way. So you let the patient lie flat with the head below, with your feet a bit above your heart level. Okay. Then you turn the patient to the left side. So you can assume you can think of that position. So it's like translembic and left position for patients suspected of having an embolism. The reason for this is that when that is done, especially for larger volumes of air that has gone into the veins, let's say 50 mils or significantly maybe an amount that's capable of causing harm. They get trapped in the right atrium, upper part of the right atrium, when you position patients like that. And it can easily be dealt with, okay, either aspirating it or whichever by the cardiologist. Okay. Some are minute in such a way that maybe they can just be absorbed or they can just swell. But if it's a large one, after that position, think a surgeon will have to aspirate it or something. They have a way of doing it. But for you, the nurse, what you have to know is that with embolism, just position the patient in that manner and tell your healthcare provider. Okay. Yes. So it's very important. If you want to appreciate it, how I understood this thing is let me give an example. When you have a sachet water, you normally have a small space with air in it, right? When you tilt it in a different way, you see how the air bubble within the sachet water moves to a particular side. Have you realized that?
Yes.
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 So it looks like that similar manner.
Even bottled water.
Yes, even bottled water. Yes, so that you can appreciate it. Okay. When you tilt it a bit down, you see you are likely to have the bubble. I mean, coming up. Okay, if you have the like in that manner. But with human position, thread limbic and left position is what is likely to help your heart catch that kind of embolism. Okay, air embolism in your right atrium for it to be dealt with. So just to let you know. Now, the next thing here is that we position clients with arms raised above head for chest tube placement. So either you see hand raised and placed on the heart, like sitting in a position with hands over a heart stable, or you see sitting in a position with arms raised above your head. It is the same for what thoracentesis and chest tube placement. The whole thing is just any position that will help open up the intercostal space. When you assume any of these positions we are talking about, your intercostal spaces will open. Those of us who have forgotten intercostal space, the spaces between your ribs, okay, they will open up for any tube to be inserted, either for drainage or for a new insertion. It's the same thing we are talking about. Any other question? All right. Now the next one, you're saying after a liver biopsy, the client should lay on the right side for at least 2 hours and then supine for an additional 12 to 14 hours. So where is the liver located? Upper right quadrant, right? That is where you find most of the liver parts over there. Okay. So what we are saying is that after liver biopsy, after we've taken samples from the liver, it's taken through the skin, then into the liver, right? After that is done, you have to lie on that side. The reason is to prevent bleeding, okay? To prevent bleeding. So you lie on that side for at least for the first 2 hours, then after supine for an additional 12 to 14 hours. The next one is thoracentesis or thoracentesis, like how you pronounce it. So we are saying thoracentesis. I mean, for that one, the patient should be upright, sitting on the side of the bed, leaning over a side table with pillow. So you see, so when they ask you, so they can say it in different form, but be guided that for thoracentesis, whatever thing it is, you will have to make sure that your intercostal spaces are open. So when they describe any position to you, then they want you to make a choice out of it. Look out for anything that opens up the intercostal spaces. Any question? Okay. Let me see. I think I have some to also add. Let me ask you. During abdominal surgery, what position do we assume? This one, someone should say it faster. Abdominal
Fine.
surgery, what position?
Supine.
Supine. Good. Cardiac surgery,
Supine.
Fine.
that is also supine. That's correct. Please, those of us who have forgotten what supine means is that you make the client lie flat on their back. Okay, so that's the meaning of supine. If you have forgotten, all right. Then, what about prone position? What procedures can we assume prone position?
Kidney.
When someone is
Incision
having,
and drainage
come again.
at the incision and drainage at the back.
Kidney.
I can't hear you.
Kidney procedures.
Kidney. Are you
Incision,
saying kidney?
Yeah.
Kidney, do you lie on your side or your back?
Prone.
Sorry. Do you lie on your side or you lie prone?
You like prawn?
Okay. Okay.
Fine.
All right. So prone positions like back surgery, okay? Like spinal surgery.
Mm.
Yes, you have to lie prone. And our kidneys are more, they are on our sides, okay? They're on our sides of the body, but they are more to our back than to our front. So sometimes it can be accepted, okay? Yes, some people say lie on the side, but I was also thinking like how practical. I mean, I was thinking about how practical it is, but
I saw a
yeah,
question on simple nursing and then it said prone.
it says prone, right?
Yeah.
Yeah, okay. So I think whenever you see prone, you are not going to see lateral. Maybe, I'm sure. Okay. Yeah, but I think prone is better. And the reason, so the reason for the prone is what I just explained, that you have the position, anatomical position of the kidneys, that they are at the back side, okay, to your side, more than the front side. Okay. Which procedures? Okay, let me ask you. Um, when you want to give enema, what position do you assume?
Lateral.
Sims.
Same
same
thing.
Lateral.
Lateral or recumbent.
Same position.
Yeah, same
sorry,
is better.
Hey.
you lie on your side and then you
Sims.
raise one of your legs
Is someone talking
towards
to
the
us? Gifty, you hand yourself.
No, because I just wanted to know if the point two do all the same at all the positions at the same time.
You said you want to know which one?
The point two,
Uh-huh.
do we do all the positions at the same
Yes,
time,
at
the
the
three
same
positions
time.
at the same time, or we
It's at the
okay?
same time. So this is how it looks like.
Almost 5:30.
Let
Five
me show
minutes.
you. And please, on the ankles, okay. So bear in mind on the ankles. Oh, sorry. Bear in mind on the ankles, they can give you pictures for you to just choose the position. Do not just say it. So it's good you've even brought that idea. So let's see position for body. So look at it. Yes. So let's look at this one. Oh.
My airtime isn't coming. But you went out today.
So can you see this one? Can you see this one here?
Yes.
That's lembec and on the left side. Have you seen it?
Yes.
So that's how you see the position. Okay. So all that we are talking about on the end list, you can be given pictures like four options. Option A will be one picture, option B will be another picture in that manner. So as we see them, know how they are. It's good you've brought
Oh
that.
no, go back. Please go back. There's something. Sorry.
Okay. So you
Okay,
see
so on the second row, there are multiple
this one.
like the second row, the second picture.
Is it this one?
Yes. Yes. What's that
Okay.
too? Are they all
Yeah, we have these are, but they are not what you're talking about. They are different things. We have different positions depending on procedures. Okay, and some are meant for some specialty areas, not for enclaves.
okay?
Yeah. So let's talk about the commonest. I mean, the common ones
Okay.
that we can talk about that you can be
Thank
tested.
you.
All right, you're welcome. So when we say SIMS, I think we all know Sim's position, right? I don't want us to spend a lot of time over there. We know Sim's position. All right. Then the next thing to also talk about is when you're giving rectal procedures to you, assume the Sim's position is very important, right? When you want to perform vaginal or let's say gynecologic investigations or okay, let me be specific. If you want to do cytoscopy, sorry, not cytoscopy, like cystoscopy, what position should you assume? Cystoscopy.
Lithotomy position.
Good. What about vaginal delivery?
Lithotomy
Little.
position.
Gynecological surgery.
Lithotomy.
For lithotomy, I don't think someone will ask me to project the picture. We all know lithotomy. Yeah. All
No,
right.
No.
it's a
Google it
guy.
on your
I
phone.
meant no.
Okay. All right. Now let me ask you. After lumbar puncture, a patient. Okay, let me ask you. I just wanted to trick you. Okay, so after lumbar puncture, what position should you lie?
Supine.
Is it wrong to lie prone?
There will be leakages. Sorry.
Yes, it's wrong.
That is wrong.
No,
Okay,
sir, it's not wrong because it's flat, any flat position.
Yes.
good.
You said
So you remember, most of the times the key word is to lie flat after what lumbar puncture. You remember,
Yes.
and flat positions can either be supine or prone.
Okay.
That is a tricky one. Okay, so normally I know we are used to the supine. If you see questions on, let's say, position after lumbar puncture, and you don't see supine, then there is prone. That could be your answer because it's also a flat position. But most of the times between prone and supine, they are unlikely to bring both of them together. But should they bring them together, choose supine. But they are very unlikely for them to bring them together because they are all flat positions. And
Okay.
sometimes they remove the supine because they know every nurse who is going to write an case knows about that. So they will intentional. I mean, they might intentionally bring prone for you to know. or for you to think whether you can consider it as flat position and acceptable or not. So take note, okay? I hope you understand what we are trying to say. You know what to prioritize. If you find the two, you know which one to choose. But if you don't find the supine and you see the prone, that is your 100% answer. All right. Then catheterization, after cardiac catheterization, um, last time I think I was trying to prepare a lesson. I think we have it on our slide. Sorry, on our notes, so on our dashboard rather. But maybe in the nearest future we shall do all these things again. Okay, percutaneous coronary intervention and cardiac catheterization, all of that. So after cardiac catheterization, what or how should we um, keep patient in terms of positioning? Can they sit upright?
No.
Can they bend their leg?
No.
No.
So the trick is that they should keep their legs straight.
No.
So when they ask you, okay, after cardiac catheterization, like it can be in the form of question that which of the following should the nurse intervene? Then there will be, option A will be like a client lying in the same position 2 hours after cardiac catheterization, or right from the cath lab after cardiac catheterization. Okay, and second option, it can be like a patient sitting in his chair maybe sitting in his chair in his room, okay, trying to read something. So they'll just give you options just to lure you away from what is really happening. So any position that makes you bend your leg is not acceptable after cardiac catheterization. So take note, okay? You have to keep your leg straight and your head end of elevation, okay? Your head of bed elevation should not be more than 30 degrees. Please keep this one. It's very, very important. They can ask you, okay? You don't have to keep it above 30 degrees. It should be less than, or the maximum it can go is up to 30 degrees. So it means you want them to lie as flat as possible. All right. Okay. Then the next one, after thyroidectomy, what position should we assume after thyroidectomy? Let's talk about this faster. After thyroidectomy, what position?
Semi-fouled.
Semi-foulness.
Semi-fowless is good. Yes, it's good. What about after tonsillectomy?
High
Uh,
foulness.
High fowless. Are you sure? Which one will help prevent aspiration?
Semi-flawless.
What about sideline? Between semi-fowless and sideline, which one
Uh,
will you choose?
Yeah,
leg
sideline.
Side.
lining.
Side.
Yes, or recumbent, yes. So sideline is better. Okay, after tonsillectomy. After tonsillectomy, if you see that your patient is swallowing a lot, whether saliva or whichever, patient you see that patient is swallowing a lot. I hope you remember that it's an emergency, right? It could be
Yes.
that
Yeah.
patient is
Yes.
bleeding.
Kind of
Yes,
bleeding.
Patient is
Bleeding.
swelling
Patient
a
is
lot.
bleeding.
yes. So always take note. Remember, I told you there are some things among us, everybody in USRN should know. So if you are here, you don't know, it means you are not following things. Like,
Mondays and
It means that what? I don't know the meaning of.
let us say it again for those who are hearing it first to also take note. If
Em-
a patient comes right after the tonsillectomy procedure is performed, then patient is seen to be swallowing a lot. What does it mean?
Sign
The
of bleeding.
client is bleeding.
Means the patient is bleeding. You know your tonsils. Tonsillectomy is like your tonsils is at the back of your throat, right? There are two over the left, right. We have upper ones too, and I think lower ones. Okay, but whichever. When the tonsillectomy is done, and it's like an necklace thing that everybody should know. When tonsillectomy is done and after, you find out that the patient keeps on swallowing a lot. Suspect sign of what bleeding. All right. Then what else can we see? What other position can you remember? I've exhausted all what I can remember. All right. And let me ask you one last question. What position helps with breathing generally?
Oh, how do you call it?
Semi-powerless position.
High Fowler.
Oh
Tripod.
yes.
So high Fowler's position, okay? High Fowler's position improves breathing. When it comes to COPD patients,
Tripod.
that is where tripod will come in, right?
Yes.
Okay. So that tripod position, I hope we all know what it is, right?
Yes, the patient will sit down and lean forward.
Lean forward. Sit and lean
His
forward.
hands on the knees, like that, something like that.
So you see it here. Tripod position, even in COPD, you see it here. So you see how it is.
Just like that.
Okay, so that is tripod position. So it helps them.
That one for the child too.
Yeah, so yes, that's tripod position for the child.
Okay.
Yeah. So if you see pictures and you don't see them, like if you get questions and they are in pictures, that's how you recognize tripod position. Okay. All right. All right. So I think we've consumed this one so we can continue. Now let's look at something here. I want us to talk about these two things briefly. Occupational therapy and physical therapy. We are saying occupational therapy teaches activities of daily living, which include bathing, dressing, cognitive or perception issues, right? Whilst physical therapy focuses on mobility, ambulation, ability to walk, use the walker or other assistive device. So you see, there's a trick here. They are saying physical therapy focuses on what? Below the waist. So this is your trick. I'll give you an example so that you can appreciate it and how you see them in questions when they are asked.
So good evening.
Okay. Then occupational therapy focuses something like above the waist. So it is assumed that way. Okay. Occupational therapy focuses on things above the waist. Then physical therapy focuses on things below the waist. That is rehabilitation. So let me give you an example. Look at occupational therapy. Okay. We are saying they help they are things that or activities that helps the client to perform activities of daily living. So an example is the bathing and the dressing that we have here. Okay. Bathing and dressing. You know, when you want to bath or you want to dress, how you can get questions correct is what I'm trying to help you understand. Okay. If let's say you have a patient and they describe what the patient is suffering from, and they ask you what kind of therapy would the patient benefit from? Will it be occupational therapy or physical therapy? So this is how you know the difference. Occupational therapy, if the things are above the waist, you go for occupational therapy. You know, if you want to bath, you use your hand. Your hand is above your waist, right? If you want to dress, you use your hand. Your hand is what? Above your waist. Okay? Cognitive, your head is also above your waist, and perception issues. So that is one trick for you to differentiate between occupational therapy and physical therapy. Okay, if you want to feed, it's above your waist. Okay, and if you want to perform any fine motor skill with your hand or your fingers, if you want to use any device, look at it. If you want to use any device, because you are using your hand to use the device, so that is occupational therapy. Physical therapy, like you are saying, focuses on what? Mobility, ambulation, ability to walk, use of walker or other assistive devices. Okay. And we are saying physical therapy. For physical therapy, you have to focus on below the waist. Okay. So an example on physical therapy is what you have like walking or ambulation. Okay. If it has to do with gait training, like gait. You know, gait is below the waist, right? Um, assistive devices like the use of canes and crutches. Okay, that one helps in walk. That one helps in ambulation, right? So you can. That one is more of what? That one is more of physical therapy. If let's say they want to teach you a particular skill that you perform with your hand, of which is not ambulation, go in for occupational therapy. But if it is for movement, like for mobility and for strength, okay, if it's for gaining balancing and all of that, go in for physical therapy. You get a difference? Anything that is used for walking, go in for physical therapy. Anything that helps develop your skills, go in for occupational therapy. So I think I had a question somewhere. So okay, so let me ask you this. A client who cannot button shirt after stroke, between occupational therapy and physical therapy, which one would the client benefit from?
Occupation.
Occupational.
Okay, the next one, a client who cannot walk after hip surgery.
Physical
Physical
therapy.
Physical
therapy.
therapy.
Good. The next one, a client who has swallowing issues.
Occupational
Occupational.
therapy.
Occupational.
You
Speech,
see, I've played
speech
you. I
therapy.
didn't mean it.
Speech
Speech
therapy.
therapy.
Speech
Hey,
therapy.
Yes.
it's true. You
Speech
trained
and
them.
language.
You see, I've played you.
You trained them.
So when
It's
you have
true.
Oh,
a patient, when you have a patient
therapy.
who has when you have a patient who has issues with swallowing, you call the speech therapist. Okay.
Therapy.
Yes. So the speech therapy doesn't mean that you're going to teach patient how to speak alone. Okay. They also assess swallowing and they clear patients whether they can take in food without aspirating. Okay, without aspirating or not. So when it comes to swallowing issues, please, is speech therapy. Okay. Okay. What about client who has difficulty in feeding him or herself?
Occupational.
Are you sure?
Feed. It
Yes.
has
Occupational
to do with the mind.
therapy.
Speech.
Unless maybe the patient is finding it difficult to swallow, that's when there's speech. Or if like normal feeding, and the occupational therapy.
Okay.
Yeah, I agree.
Some people are not sure. It is true, okay?
Hey,
Some people are not sure. They will pick answers and they will run away when you say, "Are you sure?" All right, so it is true, okay? Yeah, clients. What was the question I asked? Client who has
Client,
difficulty feeding, right?
yeah,
What about clients who cannot stand without assistance?
physical therapy,
Physical therapy.
Okay. A patient who has aphasia.
speech therapy,
Speech therapy.
That is correct.
Speech therapy.
Um, a patient who cannot hold a spoon.
Occupational.
occupational,
Occupational.
A patient who
Occupational.
cannot maintain balance.
physical.
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 All right. I think we've mastered this enough. So
So,
whenever you get this, yeah.
boss, where does physiotherapy comes in?
Oh, so it's the same thing like the physical therapy you're talking about.
Oh, okay. So physical and physio is the same.
Are they the same?
That's what I'm asking.
Someone should someone should answer that for us. I
Yeah,
think
they
we have
are the same. They're the
yes, they are the
same.
same. I think so.
Oh, okay.
Okay, so they are the same. All right. Let's see what we have. I think we shall surely complete this one right now. And I'm glad with how we are going. All right, now let's talk about the next thing here, radioactive disasters. Radioactive disasters. When it comes to radioactive disasters, one thing you should know is that this is a very serious thing. Okay, it's a very serious. No one would want to be exposed to any radioactive substance, right? And they normally happen when you have accidents with nuclear power plants, nuclear reactors, sometimes with some bombs, okay, some bomb exposures or dirty bomb exposures, or even sometimes among industries or companies, okay, when they have, there are some industries or companies that make use of these radioactive substances, and when you have accident happening, you can have people being exposed to these radioactive um, substances, or you have radioactive disaster, right? Now, the golden rule is that always protect yourself first. Okay. Remember, I told you, even if the person is dying, protect yourself first. Because if you don't stay alive or if you don't protect yourself, how can you help others? That is a common logic. Okay. So on the end case, no matter how the situation is cited, if the patient is in severe distress and the question is telling you that maybe the person is coming from or the person has been exposed to either a chemical pain or maybe a chemical anything involving chemical exposure, like an industrial chemical or a radioactive something, please, the first thing is to protect yourself first. Because the nurse, you are an individual, you have your own life to care for. That is number one. And that is not even what we are even talking about here. You are also caring for other patients. Okay. So if it's something that can easily spread, when you pick it, you endanger yourself and you endanger more other patients you are caring for. So you rather cause harm than good. That is why it's always the priority to save yourself first. before you try saving others, because you might end up causing troubles all over. Okay, so what you have to do is to protect yourself first before you can help others. So if patient comes and the patient is even in distress and all of that, remove their clothes, anything that is contaminated, remove it before you start caring for the patient. So when you see options like what will be your priority action? One, maybe patient, let me cite the question well. Patient after maybe exposure to a chemical, an industrial chemical accident, or maybe a radioactive disaster, comes to the ED with severe shortness of breath. What will be the priority action for the nurse to do? One, take or remove, send patient to isolation and remove patient's clothing. Option two, give non-rebreather, maybe give 100% oxygen via non-rebreather mask to help with breathing. Then three, you have other options. Please, between the two, don't don't be tricked. Over here, safety is important than your ABC. So the first thing is to go and remove the source of the harm before you start caring for the patient. So in this case, in this example I've given you, it is either if it's a chemical thing, you go and wash patient before you start treating. So that becomes a priority. If it's an exposure, that's um, maybe in that sense an absorption. Sometimes some of these radiations they can get absorbed by sometimes the clothes that we wear and some other things. So you remove where there is a potential harm coming from. So you remove the cloth, you wash patient before you start caring for the patient. So they become priority over oxygenation. Okay. So always stay alert. All right. Then we are saying that these things depends on three main things. Okay. The time you spend close to the exposure or to the disaster will determine if you will survive or not. And that will also determine how contaminated you are. Okay, the time limit you spend or the time limit of the exposure to that radioactive substance. Then the next thing to also talk about is the distance between you and that radioactive substance. So if let's say someone is about 10 meters close and another person is about 20 meters or 15 meters close, the person with 20 meters close is likely to get the full effect compared to the one who is about maybe 50 meters away from the exposure. So distance is also part. And
Hey, people are making noise.
the last thing to also talk about is shielding. When it comes to radioactives, but this one's with the shielding, it happens in a well-controlled environment, like in workplaces. When those accidents happen, we have shields that you can put on and all of that. So the next one is shielding. Shielding is the use of protective barriers. Some of them contain is it is it mercury or yeah, something like that.
Lead.
But I mean they are protective clothes that are used to shield, whether actual shields or protective clothing. Okay. So time, distance, and shielding is what we have to consider when there is any radioactive disaster. So what we have here on our slide, we are saying do most good for the most people. So that is what we are talking about. Do most good for the most people. As much as you can save them. And you have to save those who were far from there. So I'm telling you the tricks in it, even if I can give you examples of persons on it. So if you have someone who was very close to the radioactive substance, and you have someone who is far from the radioactive substance, please, this one, you take care of the one who was far from the radioactive substance before the one who was close. Are we there? So it's not like this thing is like that's why we are saying do most good for the most people. So you can't say because the one who was closer and be more close to the radioactive source will need more help. So you treat that patient first than the one who was far away. For this one, it's different. Treat the one who is far away than the one who was closer because the one who was far away has a higher chance of survival than the one who was close. So this is the Enclave's take on these topics too. Okay. All right. What else can we talk about?
Raima,
Yes.
please explain the second point again. The one who is far away. I didn't get that point.
So okay, so you're saying start with victims farthest away from the radioactive explosion. So you are saying when you want to treat patients, right? Treat those who are far away from or who were far away from where that incident, where that radioactive accident happened, even though they've been exposed. But because they were far from the main source, they will have only little absorption and they will have high chance of survival if you treat them. So you have to treat them first than those who were more closer to the source of the explosion or of the radioactive disaster, because those people they have low chance of survival. Do you understand?
Yes, yes. Thank you.
Yes, you're welcome. So that is one rule about this. Okay, and let me also mention this. When it comes to radioactivity, when you have children and pregnant women, most of the times they are being taken care of first. Okay, and there's one thing. Let me mention this to you. We have when you're exposed to this radiation, how how you are being diagnosed, or how we can know. Okay, should I say no? Let me be more careful with my words. So we will know because of what happened. When it's been narrated. Okay, if we know the strength of the radiation and your distance and everything, we can know whether you've been exposed or not, and we can test you. But signs, let me say some signs and symptoms you can show. The early signs and symptoms will be the GI symptoms. When we say GI symptoms, first of all, think of nausea and vomiting, if not anything. Okay, think of nausea and vomiting. Then sometimes you can have diarrhea, then fatigue. Okay. Yeah, so they are normal GI symptoms and early symptoms that come. But the later symptoms, and those are the biggest issues. We have bone marrow suppression. Okay, when your body absorb all these things, they can cause cancer, bone marrow suppression. When you have bone marrow suppression, the last time we talked about it, you know what will happen. Can have infection, bleeding, and all of that, right? Okay. So I was about saying something. Yeah. So to sometimes especially remember I said especially among children and pregnant women, when they are exposed to radioactive iodine, for instance, okay, it's one type of radioactive substance that can be involved in radioactive disaster. When they are exposed, we can give them something we call potassium iodide. Okay, potassium iodide. And what the potassium iodide will do is to prevent them from getting this thyroid cancer. Okay. When I'm repeating myself on that side again, just in case you get questions on it. Radioactive iodine or iodine, they can be very dangerous to anybody at all. But those who are very susceptible are children and pregnant women. Okay, because of the nature of their immune system. And what radioactive iodine can do is that they can let you get um, thyroid cancer. Okay, yes. So when most of the times you have children and pregnant women being exposed to radioactive iodine, the first thing you do is to give them what potassium iodide. And what the potassium iodide will do is that it will protect their thyroid glands, okay, from getting cancerous. Are we there?
Yes. Yeah.
All right. So that was just an additional thing to add up. So yes, so I got this thing here that contamination principles. Yeah. So this was what I was talking about. Remember time, distance, and shielding. Minimize your time of exposure. That will increase your chance of survival. And maximize your distance. Make sure you keep a vast distance. Okay. Use protective barriers. Okay. So I think I have some questions here on that. Let us look at these questions first. We have to finish this one so that we don't come back next week on this topic again. Someone should read this one for us. Okay, a client arrives from a nuclear accident scene with visible dust on clothing. What's the nurse's first priority?
Remove clothing.
What is it?
You remove clothing.
Remove clothing.
You're laughing at the question there. because it's too cheap. Because it's too cheap, you're laughing at the question. Let's look at another thing.
Oh,
So we didn't
Client,
look at the question again.
hey, madam.
That
Hey,
was
madam.
not.
Madam, everybody said it was too cheap. You didn't see the question.
hey.
Everybody said it was too cheap.
So we're reading now, and then you showed us the answer.
Oh, someone said it.
Oh.
You see that someone is saying, oh, it means, he didn't even notice that it was easy because I kept on saying this. Remember when I was
Yeah.
explaining, I kept on saying it. Yeah, so can we go on now?
Yeah.
Okay. So look at this question too. Which client should receive? I just explained potassium iodide. So if you listen very well, you should be able to get this question correct. Which client should receive potassium iodide? Yes.
One,
Is the first one correct?
two,
Yes, 1, 2.
Mm-hmm.
4.
Breastfeeding mothers. Yes, 4.
Yes, 4.
Cannot do so.
Is that all?
Yeah.
Are you sure or is just lottery?
Oh.
9 to 8. Yeah, validation system.
Adults with external
I
radiation.
think 5 says
I think
part.
5
5,
too.
5, 5.
5.
Are you
Okay, so
sure?
you're choosing 1, 2.
Yeah. You know.
You're choosing 1, 2, 4, 5. Are you sure?
Yes.
This are you sure, dear?
Yes.
Someone doesn't like are you sure? Okay, let's see if we are sure.
Yeah.
The answer is 1, 2, 4.
Hey, 1, 2, 4.
1, 2, 4. You see?
Can you go back, please?
The answer is
1, 2,
1,
4.
2,
That's
4.
what I
Okay.
was supposed to read.
Oh, Saima, are you sure?
Because you said children
Oh,
and pregnant
if you
women.
are sure, you are sure. If you are not sure, you are not sure.
That's
Yeah.
shows.
Uh-huh. Okay, so the answer is 124. Please, have you gotten it? Can you move on? So take notes,
Yes.
okay, when you see things like this anywhere, so that you can be able to answer. Can we carry on?
Sorry, ma.
Yes, sister.
Some of us are just listening. Can you please tell us
Hmm?
the answers? Some of us are just listening.
No, the
Ah,
answers are 124.
so they want to hear the answers itself.
They're not
Pregnant
watching the screen.
pregnant women exposed to radioactive iodine, they can receive potassium iodide. Then the next one, child near nuclear power plant should also receive it. Then the last one, breastfeeding mother exposed to radioactive iodine.
Okay, thank you.
You're welcome. Now, this is the last thing to talk about. Then we will close the chapter. So, we know Jehovah Witnesses, we care for um, we care for patients from different backgrounds, right? Some, I mean, the United States, Canada, I think it's more of the United States. It's made up of multicultural than even Canada. I don't know whether it's true or not. But within these two countries, you have lots of different cultures, right? It's not like somewhere in Africa where you can have maybe three main religions. We have lots of, even among Christians and other religious. I mean, but this we study Jehovah Witnesses because it's a very big thing that I mean it's been part of medicine right now. And it's a very huge thing. That is why we have to take note of it. And the English ask questions on it. What we are coming to talk about is not anything new to us. We already know that Jehovah Witnesses do not accept blood and blood component of any type. So let me ask you this. I mean, there are two bulleted points here, and it summarizes the whole thing. It makes it simple. Option two, bullet two says they do accept normal saline, like treated ringgits and other crystalloids. Okay, and they accept epoetin alpha too. So just note that they accept epoetin alpha, but they do not accept blood. Sorry, they do not accept blood components of any type. So let me ask you, do they accept FFPs, fresh frozen plasma?
No.
No.
No,
Do they
No.
accept PRBCs,
No.
no,
No.
please.
whole blood?
No.
No,
No.
please.
So anything that has blood or that is
No.
pulled out
Blood
of blood.
component.
Honest.
Okay,
No.
even plasma, right?
Mm.
Or they can receive plasma. Can they receive plasma?
Mm.
No, please. It's a blood component.
Anything that
The
is
blood
extracted from
component.
blood. Okay, so they can't receive anything. So always pay attention when questions are thrown around such areas. So let me ask you a question. Um, there are dicey questions around this. Okay,
Hmm.
when a patient comes to the hospital, and I think for now, is it? Do you have a Jehovah Witness here? I think we have some here, plenty. Don't hide yourself. Help educate us. I think at
Mhm.
first they, I mean, like they were for now. Okay, for now, I don't know. I'm not too sure. That's why I don't even know how to say it. I think they carry a tag or a notification something
I think they still do.
with them wherever they go, right? Please, is it true?
Yes, we
Yes.
always have that
We
with
still
us.
have them.
Good. Yes, yes. I think at first it wasn't like that, right?
It's always like that.
It's always like that.
That's okay. Yes. Okay. Yes. So whenever let's say mistakenly, God forbid, let's say if there is an accident somewhere and this patient is sent to the ED, most of the times you have to search for any possible thing, whether the patient has a DNR or the patient is having a condition. We have to search for everything that we can find on the patient. So let's say in the process of searching this patient, you find this notice that says I am a Jehovah Witness, or I don't know what is written on it, but that indicates that he or she cannot receive blood. Please, it is a legal document telling you, the healthcare provider, that you should not give blood to this patient. Any other way that you can help, like crystalloids, and we have this equity, we have other drugs and other ways of boosting hemoglobin. Okay, even though some of them take time, but they are not entirely ineffective. Okay, so use all those ways. If there is a gap that you delayed, or maybe you slowed because you were not able, or you couldn't stand, or let's say you were not in the right, how should I even put this? You see, some people can have a withdrawal attitude, okay, and they can be pissed off that why, I mean, the patient needs blood. We've seen some in our emergencies before. Okay, so even though it's not acceptable, but sometimes we see them. Okay, yeah. So if there is any evidence that the healthcare provider or the team delayed because the patient cannot receive blood, and maybe the healthcare team delayed to use other alternatives to save the patient, even if there's a delay, just because the patient cannot receive blood, it's a very, very big issue. Okay, so I mean, I'm trying to look at the portals around. When you get questions around these things, you know what to do and you know which answer to choose. I think let me see what we have here. So that's the end of my presentation. We've gone a long way, right? Prioritization, fundamentals, delegation, and prioritization. This, remember, we've not talked about everything on fundamentals. We can treat fundamentals for the next 2 or 3 months, okay, which will make no sense. So, like we always tell you, there's always something there for you to learn. We'll give you what we think is better from time to time. Whatever thing that you find anywhere, you can go through and also read. If you have issues understanding, we are there for you.